everyone, and welcome to today's webinar, Clinical Value of Measurable Residual Disease Assessment in Multiple Myeloma. I am Sydney McNeil of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Cytognos. To learn more, visit cytognos.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the bottom of your screen to obtain your credits. I'd like to now welcome our speaker, Dr. Juan Flores-Montero, postdoctoral researcher, University of Salamanca, Salamanca, Spain. Dr. Flores-Montero, you may now begin your presentation.
Well, good day everyone, and thanks a lot for that kind introduction. It is a pleasure for me and also a responsibility to be here today in this webinar. I would like to express my gratitude to Cytognos for their kind invitation and also to LabRoots for their support on the organization of this event. We'll be talking during the next minutes about the clinical value of MRD assessment in multiple myeloma and discuss how this is currently being done, what for, and also a glance what might be coming around the corner next. In between, we will highlight some of the matters that, despite the available evidence, are still a source of discussion. Thanks for joining, and I hope you find all this information useful. Before we start, just let me show you for a few seconds my potential sources of conflicts for this presentation. And now, without further delay, without going into much detail, I will just start with some background information to situate ourselves in context. I will just briefly mention the general characteristic of myeloma disease just to highlight the key aspects used to establish the diagnosis. First of all, accumulation of clonal plasma cells in the bone marrow or other tissues. Secondly, identification of monoclonal components. And third, the occurrence of well-known clinical manifestations that are consequences of the previous two aspects. Additionally, these and other complementary parameters like cytogenetic profile are investigated to be able to identify the risk category of any given patient. Establishing the diagnosis and defining the risk group just precedes the planning for a therapeutic intervention, which aims to modify the natural history course of the disease and provide patients with a better quality of life, to prolong his or her survival, and possibly to offer even a cure. After the therapeutic intervention takes place, we need to evaluate its effects on the patient. And this is to say, we need to investigate if the treatment was effective and to quantify how effective it was. Minimal or measurable residual disease strategies are designed to identify remaining traces of the disease, even if they are subtle, after the therapeutic intervention, by demonstrating the persistence of the whole clonal cells or their genomic material or signs of their activity on the possible sites of accumulation. Regarding therapeutics, this has been a very active field in the past decade, with an ever-growing number of drugs approved and many other investigations to treat distinct groups of myeloma patients. Consequence of the better understanding of the disease biology, we have moved from a more classic group of drugs to evolve new representatives of their families, but also to fully new agents with novel mechanisms of action. Particularly those included in the other category at the bottom part of the table. This category includes the newest incorporation. Here, the bispecific antibodies and the antibody drug conjugates being currently a very productive territory. Many of these substances have been explored initially as a single agent, but you know that most common scenarios involve actually multi-drug regimens. Furthermore, Several different schemes of similar combination of drugs, that is to say, different doses, number of cycles, etc., are always under evaluation. Clinical decisions and selection of specific treatments are dependent on many different aspects, like patients and disease characteristics, prior treatments, or therapeutic resources availability. At the end, every single approach has the aim to achieve the most effective and lasting tumor load reduction. The different therapeutic strategies have become more and more efficient in accomplishing this task, with an increasing number of patients reaching deeper levels of response. Nonetheless, even within the group of patients achieving best responses, clinical course is still heterogeneous and a group of them still relapse. One of the most evident causes of relapsing is the persistence of measurable disease. There is unmeasurable disease. This is to say that this a portion of the disease that we were not able to detect. This is the very reason pushing the field forward to develop more efficient and sensitive strategies to evaluate this condition. The International Myeloma Working Group has refined in 2016 the criteria to evaluate the responses to treatment in multiple myeloma patients beyond complete remission or stringent complete remission, to establish a common language and to establish also a reference frame to discuss and compare the results. It also pointed to the reference tools available for this evaluation, which are the ones currently achieving the highest sensitivity. They have also outlined in this recommendation how the results should be interpreted. Each one of these tools approaches MRD assessment from a different perspective. In general terms, it shows two major distinct groups of strategies. On one hand, the one that evaluates intermedullary involvement, and that includes next-generation flow and next-generation sequencing, and on the other, those that search for the disease outside the bone marrow. A side-by-side comparison of those methodologies looking for the disease in the bone marrow will allow to identify their respective strong points and also their limitations. In general terms, they are both extremely efficient techniques that allow high sensitive detection of MRD levels. While differences are evident when they look into availability, to some extent applicability, time required until results are generated, relative complexity, and perhaps cost. One of the strongest points of molecular-based techniques is sensitivity, always perceived as superior to that compared to that of flow cytometry. Nonetheless, we need to understand that in both cases, for these high-end methodologies, the level of sensitivity is very high and heavily dependent on the amount of sample interrogated and the quality of that sample. Few direct comparisons of bone marrow reference techniques have been made, also there are many right now ongoing. Here I show two examples, the first one at the initial evaluation of NGS, and more recently, another from the molecular team in the hematology department in Salamanca. Results show highly similar performance. Even if they look at the problem from different perspectives, in most cases, from 75 to 86%, the results are always concordant between the two methods. Regarding discrepancies and sensitivity, the evaluation favors one time each one of the techniques, but it's interesting to point out that within the group of cases positive for just one of the techniques at a time, relapses were always more frequent in the group of NGS positive next-generation sequencing negative results. It is also worth it to stress that within the double negative group, some progressions were also registered. The key aspect to stress here is that both are very efficient techniques, that they are significantly and positively correlated, and more importantly, that they have both similar clinical impact. The same profile is also observed in a similar comparison performed at the Memorial Sloan Kettering Cancer Center, where they have a single 10-color tube high-sensitive flow cytometric approach with a similar performance compared to NGS. In these comparisons, overall concordance is higher than 90%. and the few discrepancies this time favor NGS results. The International Myeloma Working Group already indicated that MRD negative status could be defined by using any of the two approaches, since the two are alternative methodologies. As you may observe, the survival curves are to most extent superimposable. Thus, the selection of one over the other would probably correspond to local availability, degree of local expertise, cost of the practice, and other practical considerations. You probably all know NGF and the most evident aspect of the methodology, that is, the combination of cellular targets investigated to detect clonal plasma cell population and the sample preparation protocol which guarantees a sufficient amount of cells to sustain the high sensitivity claim. But I just wish to highlight now the third strong point of this methodology, which could be the one of additional advantage over the molecular method. At the same time, we get an efficient answer on the principal question, that is, whether the patient is MRD positive or negative, based on the complementary analysis strategies and tools. We double the amount of information obtained from each sample, and we optimize the analysis time. Thus, the analysis intrinsically contains complementary information that we are all starting to observe and to establish their clinical value. We can establish the quality and representative of the sample based on molecular bone marrow associated population, to identify related or unrelated hematologic conditions coexistent with the minimal residual disease, and to better understand the biology of the disease, or finally, or ultimately, to identify potential biomarkers with prognostic significance. We have already mentioned that in spite of the high sensitivity of bone marrow MRD assessment, some patients within the MRD negative group still relapse. These patients show a very interesting profile, since for some of them at the time of relapse, the monoclonal protein was not detectable or the bone marrow clonal plasma cells could not be identified. And particularly in this later group without bone marrow involvement, in this cohort of patients from the Spanish M trial, 5 out of 7 of them presented extraosseous plasmacytoma, some of them present already at diagnosis. This will be particularly an important group of patients on which the search for residual disease outside the bone marrow is critical. In this regard, similar to medullary approach, PET-CT results yield clinically relevant information and help to identify patients at significantly increased risk of relapse in all published data. Even if its overall prognostic significance seems to be lower than the bone marrow techniques, this doesn't make it any less relevant. Imaging complements the evaluation of patients with extramedullary disease at diagnosis and in those patients with no evidence of medullary disease at follow-up. So, inserting this methodology in the right place within the follow-up strategy will enhance the quality of its prognostic information. The fact that multiple myeloma MRD detection could be now a trending topic doesn't mean that this actually is something new. Results have been generated for almost 2 decades already. It is true that before these results were generated with less sensitive approaches. Nonetheless, they have always clearly pointed to the same direction. Despite this topic still raises some discussions and some aspects remain controversial. There are many research work, meta-analysis, and currently ongoing clinical trials specifically designed, among other objectives, to start providing answers to these questions. For example, is complete remission enough? Well, it is perhaps surprising that this question is even asked these days, but it is. Many debates still take place around this issue, with a not negligible amount of scientists or clinicians sustaining that MRD investigations are not essential or that they remain as a fully investigational tool. In contrast, I believe that we all agree already for quite some time that in the first hand, patients in CR are a very heterogeneous group with different clinical outcomes. And secondly, that the current therapeutic strategies are increasing the number of patients in CR, making this a more populated category and even more heterogeneous. But in any case, MRD studies have always shown that no matter what methodology is used, or even if we use different levels of sensitivity, the group of patients in CR can clearly be split in two groups with very distinct risk of relapse if we add MRD information on top of the classic criteria. Actually, achieving CR without becoming MRD negative is almost as fast as achieving any less quality response. Actually, MRD measurement surpasses the risk stratification and diagnosis with any of the current available risk group assessment approaches, even those based on high-risk group cytogenetics. It is important to highlight that the data also suggests that whenever patients fail to achieve MRD negative status, the discrimination power of this stratification tool is retained. As a matter of fact, there is a great body of evidence showing that MRD always has an impact on progression-free survival and or overall survival. And as I just said, despite the methodology used, and even when highly different operational performance of these methodologies are considered. Actually, several meta-analyses have evaluated the relationship between MRD and progression-free and overall survival in an important number of publications involving a high number of patients, yet again demonstrating that in all cases MRD negativity assessed by any of these high-sensitive methodologies is associated with prolonged progression-free survival or overall survival. As an example, the largest meta-analysis from last slide reported a net reduction effect of MRD negativity on progression, on the risk of progression and or death, providing even more robust support for systematic MRD investigation. I would like to highlight again that the effect of MRD negativity is independent of the sensitivity threshold, methodology, diagnostic risk group, previous response criteria, and the time point of evaluation. But please be careful with interpretation. For example, according to last slide, can the scientific community just accept dichotomic MRD results? Would saying positive versus negative result be sufficient? Well, the answer would be no. And to be fair, your level of sensitivity should be clearly stated in your report. If you decide to go for a less sensitive method, that will indeed be better than not doing MRD at all. But simply from a quantitation point of view, your MRD rate could change from 0 to half of your patients if the highest sensitivity is selected. For example, after consolidation, with the corresponding consequence for the patient if clinical decisions are taken based on this sensitive threshold. We need to encourage everyone to aim to use the highest sensitivity possible, as second best options might not be as good enough for our patients. In line, if we use information generated from the highest sensitivity technique, but stratify the patients according to different depth of responses, the impact of overlooking even very low amount of residual disease on survival is clear. Therefore, becoming MRD negative is good, but the highest level of response are the ones actually discriminating the patients at the very lowest risk of relapse. As previously introduced, MRD negativity surpasses the diagnostic risk definition at diagnosis, and therefore support the concept of dynamic risk. I already mentioned that achieving MRD negative overcomes poor prognosis discrimination introduced by high risk associated with cytogenetic abnormalities. MRD negative high-risk patients have similar progression-free survival or overall survival profile than those with standard risk cytogenetics. It is also valid the other way around. Also not as marked as before, standard risk patients with MRD positive do worse than standard risk with MRD negative, making it evident that if MRD status is not achieved, cytogenetic risk assessment retains its prognostic value. But we can use MRD evaluations beyond their prognostic power. For example, to better compare and understand the therapeutic intervention. MRD investigations are one of the fastest, most accurate, and reliable ways to compare results from different treatment arms in clinical trials. In the left side of the slide, a comparison between MRD rates after cistin induction regime is shown, with an evidence superior performance of bortezomib, thalidomide, and dexamethasone over other combinations. That advantage is clearly later translated on survival differences. Without MRD evaluation, we will have to wait until follow-up data is generated to evaluate the impact of each one of these regimes on progression-free survival or overall survival, which constitutes one of the strongest points supporting the current efforts in place directed to incorporate MRD negativity as a valid endpoint for clinical trials as a surrogate for survival evaluation. We can use MRD information to additionally evaluate what is the specific impact of any given therapeutic intervention. In this very recent publication from the European Myeloma Network HOVON trial, they aim to clarify the effect of consolidation after induction and intensification. MRD was only assessed in a subgroup of patients after the second randomization and before the start of maintenance. Results show an overall benefit effect of consolidation in the total cohort of patients. Nonetheless, when we stratified them according to MRD status by flow cytometry, achieving MRD negativity surpasses the effect of receiving consolidation or not, indicating that in the MRD positive group, the impact of consolidation is still observed. Another concept introduced by International Myeloma Working Group in 2015 was regarding the value of single measurement versus sequential evaluation, translated as sustained MRD negativity. In practice, all the data shown so far was based on single time point of measurement, so the relevance of this modality has already been assessed. More recently, different studies have investigated the value of sequential measurement, like in this recent one from Martinez Lopez group from the Hospital 12 de Octubre in Madrid. They have discriminated three groups of patients according to the level of MRD in consecutive measurements. And it is not surprising, at least for me, that the ones showing persistently negative results and those in whom the MRD levels were progressively decreasing were those patients at lower risk of relapse. In line with this, results from the ALCYONE trial show that the best survival profile is observed for MRD negative patients, particularly for those who were MRD negative for more than 12 months, regardless the treatment arm they were included in. Nonetheless, in MRD positive groups associated with the shorter progression-free survival and overall survival, patients that received daratumumab displayed a significantly better profile associated with a higher quality of response. Two additional studies have also demonstrated this. In this case, the POLUS and CASTOR trials at 12 months of sustained negativity, it becomes evident that these patients have prolonged progression-free survival. In this study, they have also shown that sustained negativity is more frequently occurring on the daratumumab-containing regime. Finally, in this single-center, single-arm phase 2 trial, in patients with continuous lenalidomide maintenance, MRD was measured yearly, and it clearly observed that persistence of MRD negative status at 2 years was associated with sustained progression-free survival rate. In contrast, loss of MRD negativity or persistence of MRD positive were associated with poor profile. Finally, when should we measure MRD and what for? In general, most clinical trials share most phases of the therapeutic scheme: induction, transplant if the patient qualifies, consolidation in some trials, and maintenance. MRD assessment is frequently investigated when the quality of response needs to be evaluated, that is to say, at the end of induction and post-transplant. Beyond these two time points, the matter becomes more heterogeneous. Investigating MRD between phases informs about the contribution of each of them to the overall patient response and support distinct experimental approaches based on MRD status. Nonetheless, in real life, MRD results continue to be mainly confined to this experimental exploration, and few already consider MRD results to guide clinical decision-making, even if we all understand that MRD are actually the most sensitive and effective way to evaluate the depth of response. Many clinical trials are undergoing to demonstrate the utility of more personalized approach that incorporates MRD-guided decisions into everyday practice. As an example, this slide shows currently active trials which include MRD-based clinical decisions based randomization. To wrap up this last point, I bring you here a very interesting data published again by Dr. Martinez Lopez. Here they show that for patients outside clinical trials in whom any kind of adaptations of the therapy was introduced after MRD assessment and according to its results, a significantly prolonged survival was observed. And once again, if the therapeutic adaptation was made on the MRD negative group, its effect was not as important like for the MRD positive group of patients. Finally, a few words on what's next. The reason supporting the systematic assessment of MRD, the indicated methodologies, specific timings, the usage of the information generated still needs to be defined, so the transitions to routine clinical practice can finally happen. There is always room for improvement on the available techniques. The high requirement for standardization is not yet completed for all of them, and we must not forget that new players will be coming on the field. Some of them are already here. There seems to be a clear place for continued and more frequent monitoring. But can we already do this with the current approaches? Well, to answer some of these questions, we need to take a look into the role of peripheral blood on the whole monitoring strategy. Long overlooked principally because of the lack of sensitive methodologies, the current scenario is different and present approaches can reach high sensitive levels. But do not forget that the number of donor plasma cells could be 1 to 2 logarithmic decades lower in the peripheral blood compared to the bone marrow. We know that bone marrow MRD monitoring has some limitations. Patchy patterns on bone marrow infiltration in patients with multiple myeloma, which may be associated with sampling bias. The fact that bone marrow aspiration is an invasive and painful procedure, and the quality of samples that may be affected by hemodilution and do not allow for an accurate determination of the tumor cell load. However, peripheral blood evaluation can be considered by means of using techniques with an increased sensitivity and provided that background evidence demonstrates the presence of circulating tumor plasma cells, and this presence yields clinical relevant information. So, can we use peripheral blood to monitor residual disease in multiple myeloma? Well, we know that once more, depending on the sensitivity of the selected method, we can detect circulating tumor plasma cells in the peripheral blood of all multiple myeloma patients at diagnosis using, for example, next-generation flow. Detection, and particularly the exact quantification of circulating tumor plasma cells, holds clinically relevant information as it helps to differentiate MGUS versus more advanced stage of the disease. It helps to detect MGUS patients with an increased risk of progression, and it also allows to discriminate multiple myeloma patients with more aggressive disease behavior, with a good correlation with other risk assessment approaches. We can use this methodology to explore the possibility of detecting those cells also after treatment and assess its clinical impact. There is a percentage of bone marrow MRD positive patients without evidence of circulating tumor plasma cells. But seeing it from a different perspective, circulating tumor plasma cells, whenever present, always mean a positive bone marrow. This is useful in the clinical setting. When considered overall circulating tumor plasma cell positivity, it was associated to an increased risk of relapse, as you can see in the upper left side of the slide. In addition, we could demonstrate that circulating tumor plasma cell positive patients have a significantly worse prognosis than those bone marrow MRD positive and circulating tumor plasma cell negative. So, per se, circulating tumor plasma cells have prognostic implications. Finally, in this group of patients, serum immunofixation results have had no additional impact over the prognostication power of the circulating tumor plasma cell status. Furthermore, the lowest risk was detected on those patients who remained or became negative in consecutive peripheral blood measurements, as you can see in the upper right panel. So all of the above allows to consider to include monitoring on peripheral blood as a relevant and informative tool in MRD evaluation. Potential application could be, for example, better scheduling of bone marrow MRD investigation. Actually, the group of Dr. Francesca Gay has proposed a model to select the MRD evaluation technology based on clinical presentation and diagnosis of the disease. Importantly, introducing a peripheral blood evaluation systematically as the initial step. You may have noticed in the last slide that already a new methodology was introduced that we haven't talked about, which has been under the spotlight in the recent years. This is mass spectrometry. Mass spectrometry is a very promising approach that is rather easy to perform, and it increases significantly the sensitivity of the classic methodologies to detect monoclonal components. Some results comparing mass spectrometry and other MRD methodologies are starting to be shared, particularly on hemato-oncology meetings. In the last American Society of Clinical Oncology meeting, Dr. Puig and colleagues shared the results within the GEM 2012 less than 65 years trial, where they compare mass spectrometry versus next-generation flow cytometry at the time point where NGF was investigated. They reported highly comparable results with around 20% of discordances, most of which correspond to NGF positive mass spectrometry negative cases. More importantly, the prognostic impact of these measurements were almost superimposable. Nonetheless, it has already been highlighted that this technology bears the same burdens as previous methodologies to detect the monoclonal component. That is, this monoclonal component can be detected for some time after the tumor cell has disappeared due to prolonged half-life of the protein. But on the other hand, it may reflect false negative NGF results because of extramedullary involvement. Further investigation is warranted to clarify the specific contribution and clinical value of this technique and define its place in the follow-up strategy. As conclusion, I will express some ideas to summarize all the presentation. Evaluation of MRD within the bone marrow can help to redefine conventional CR definitions and further discriminate different risk groups of patients. High-sensitive techniques are now available and their specific contributions have clearly been defined. Additional confirmation of extramedullary disease is very important, particularly in those patients with extramedullary disease of diagnosis or those that are MRD in the bone marrow negative. MRD is a very powerful and independent prognostic factor. Reaching MRD status should be the aim of therapy, and this category overcomes the diagnostic risk stratification and in every case is related to a prolonged survival. Many clinical trials are going to provide further evidence of clinical utility of MRD assessment. In sequential monitoring and alternatives to bone marrow MRD investigation deserve further attention and should be further characterized to define a role in the MRD assessment strategy. I would like to thank the group of people involved in the development of all this work that I've shown now, and I will be available for questions in the live session. Thank you very much for your attention.
Thank you, Dr. Flores-Montero, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, how do you deal with non-secretory multiple myeloma that does not express CD56 or CD117?
Well, thank you for that question. We must keep in mind that CD56 and CD117 are not the only aberrant markers that are present in the combination. So we may have some other informative markers to use in this case. Most of the time, the abnormal plasma cells do not show a unique or only two abnormalities, but more than that. So I'm sure that we will have sufficient information in the whole combination to evaluate in this case and be able to detect the abnormal plasma cells in these cases.
Great, thank you. Our next question is, do you perform the MRD panel on every follow-up case, or do you have a less sensitive panel to screen for overt relapse disease before performing the MRD panel?
Well, this is also a very important question, and I think that not always we get enough information from the samples when they are sent to our laboratories. So to start with, for many times we do not have the complete information of what exactly is going on or the moment of the evaluation of the patient. So whenever we get a sample that has been treated, we start with the high sensitive panel, meaning NGS, to evaluate that sample. Only if the sample is not being evaluated for follow-up or just to diagnosis, then we go for a less sensitive panel, meaning the diagnostic classification panel. So the key decision would be triggered by uniquely by the information that these patients have been treated in advance.
Perfect, thank you. Our next question is, do you use VS38 in your panels for DARA patients?
No, we are not currently using it. We have evaluated that specific marker locally, and also there have a few papers or a few results also produced by other researchers within the scientific community. In our hands, and also in some of the other results that has been shown, that marker is not that easy to get completely bright and good staining. Its expression might be compromised and different according to the sample preparation protocols and processing that you perform on it. So sometimes you can have a presence of a population of plasma cells that does not stain for the marker. And this is something that we cannot accept in the MRD investigation. So we wanted to make sure that anything that we use is working as close to 100% of the cases as it could be. So that's the reason why we have not included that specific marker.
Thank you. Our next question is, the NGF multiple myeloma MRD kit is not validated by the FDA for clinical trials, but NGS is. Why so, and what efforts are made to change this?
That's a very interesting and also relevant question. It's for sure true. We are currently undergoing putting the data together to submit the NGF methodology for approval for both for the FDA and also for the European Medical Agency. And that is undergoing currently. It was just a matter of time, and because NGS was, let's say, appeared first, and there was already some results generated that validated the technology first than the flow cytometric technology. But we are currently organizing and validate and gathering the data, putting the data together to make this submission shortly. As you know, in Europe, for example, we are undergoing currently a change in the legislation that makes us mandatory to have that authorization rather soon to be able to produce clinical results, not only for NGS but for all the clinical applications. And so this is an ongoing work.
Perfect. Thank you. Our next question is, do you think B2 microglobulin expression on the surface of the abnormal plasma cells might have an impact on the CAR cells treatment in multiple myeloma? I mean, if the patients have skewed HLA because of inappropriate B2 expression, would this have an impact on the immune synapse needed for the correct functionality of the cytotoxic anti-tumoral T cells?
Well, this is a very interesting question, and I would say that as far as I know, the levels of beta-2 microglobulin are just increased, and there's no information that I know of that points to the direction that this protein is somehow altered in its constitution or in its function. So it's just a reflection of the tumoral mass that the patient has, not only for myeloma but for other diseases. So it should not compromise the synapse needed for T cytotoxic activity. And also in the case of it has been evaluated in the context of CAR T cells therapy, because some people is investigating the option to use allogenic CAR T cells to treat the patients. And for sure, we will need to try to avoid the graft versus host disease in this type of approaches. And one of the approaches evaluated is trying to modify the expression of beta-2 microglobulin on the CAR T cells. So it will be kind of a different scenario, but as far as I know, the expression of beta-2 in the myeloma plasma cells does not impact the function of the CAR T cells.
Perfect, thank you. Our next question is, to clarify, you run the less sensitive panel first, then if that's negative, you do MRD. Which markers are in your less sensitive panel?
No, we run a less sensitive panel. It would mean that we run the panel for diagnostics, always at diagnostic. We know that even that less sensitive panel, as it's being asked or named, is actually as sensitive as 10 to the minus 4. So it's quite sensitive, but it's meant for the diagnosis, in which case we expect to have a sufficient number of normal plasma cells and a clear population of abnormal plasma cells present in the sample. That combination at diagnostic is slightly different from the NGS combination because it's meant to include some prognostic markers. For example, here we have beta-2 microglobulin, which we have just mentioned, and we have another marker like CD28 that it's also being associated with it's abnormally expressed in myeloma cells and contributes to a better discrimination of the abnormal cells. But we do not actually use this panel if the patient comes querying for detecting residual disease. We always go for the highest sensitive approach because we do not know in advance whether the sample will be infiltrated or negative. So we need to go for the best option we have in those cases.
Great, thank you. Our next question is, if you collect 20 million cells and analyze 10 million nucleated cells, what are the other events that are excluded?
Well, let's see if I understand this correctly. I guess this question comes from the sample preparation protocols, and in which we recommend to start with 20 million cells, which is the double of the number of cells we recommend to acquire systematically, which is certainly 10 million. And this comes from the fact that we always lose some cells during processing. And that cell loss could be as high as 40% in some cases. So to make sure that we will have enough cells to analyze, to reach that 10 million cells and to be able to keep the highest sensitivity that we can achieve, we recommend to go for 20 million to start the protocol with. So we, in all cases, will be able to retrieve or recover 10 million cells at the end. It doesn't mean that you need to stop at 10 million. If you have more than 10 million, you can certainly acquire as many cells as you have. In our hands, it improves over time. So even if you start, let's say, using the protocol today, you will see that you will get 10 million, around 10 million cells. And as soon as you get more familiar with the protocol, you will start getting more than 10 million. And you should certainly acquire as many cells as you have. That will only help you to increase your certainty and your sensitivity levels.
Wonderful, thank you. Our next question is, have you noticed any discrepancy in the results of tube 1 versus tube 2, as the first tube involves surface staining while the second involves cells permeabilization?
Sure. We do have observed some differences. I would say that those differences are rather minor in the sense that there are some deviations in some of the markers included in the combination that are affected by the different sample preparation protocols for tube 1 and tube 2. But since this is a two tubes approach, it actually works as a validation of the information that comes from one or the other. So even if most of the time the results are totally comparable or not significantly different between the two of them, at the end the conclusion is formed or produced taking into consideration the results from the two tubes and making an average of the two to make your final conclusion. So we do see some differences. I would say that those differences are mainly in the expression of some markers, like the CD19, for example, and a little bit of CD138. that those differences are most of the time not dealing with the numbers of plasma cells detected, and that at the end you should make your conclusion considering the information coming from the two tubes together, and that will also increase the certainty level of the results.
Thank you. Our next question is, we found number of plasma cells in flow significantly lower than bone marrow core biopsy done at the same time, likely due to loss of plasma cells in fresh sample. Do you have the same experience? Does this make an MRD negative sample questionable?
Certainly, we have had the same experience. This is a well-known phenomenon that occurs whenever we're comparing the results coming from morphology compared to the flow cytometry results. But we know already for a long time that that bias on the flow and this type of samples is already incorporated in the whole approach. What I mean is that even if you get a different number of plasma cells, those numbers or the level of the results are completely clinically relevant. Meaning that even if you get a low number, then you make all your results and your decisions based on these numbers, and this number has been validated by the clinical information. So even if they are less, they preserve their clinically relevant information they provide. And this also is the same for at the highest sensitivity level, meaning that if we cannot detect the MRD level with the combination, it means that for the highest sensitivity with that combination, the cells are absent. We should keep in mind that there are not 100% of success rate for any methodology, and there is also no gold standard for MRD detection in multiple myeloma. So the only thing that we can do is to compare with other available techniques, and most of the time, as I showed in the presentation, the concordant results rate is pretty high. And also we can wait a little bit longer and wait for the survival impact of the result. And in those two aspects, I would say that we are pretty sure that the samples coming from patients that at the end are concluded as MRD negative, we are pretty sure that at the highest sensitivity level, those samples are indeed negative.
Thank you. Our next question is, for clinical trials, we often receive later pulls of marrow for MRD, and cellularity is not always as required. Have you compared samples, mock or real, with minimal cellularity to determine how LLOQ is impacted based on cellular input?
This is also a very important question because I do not know why this is still happening. We should preserve the best sample we get for the most informative techniques. And at minimal residual disease evaluation, this is certainly not morphology. So we should try to convince the clinicians and the whoever is in charge of taking the bone marrow samples to send the most informative samples that you can expect to these high sensitivity techniques evaluating MRD. We have indeed evaluated the effect of hemodilution, both, let's say, in silico generated material and also actual dilution with peripheral blood. And there are some other groups that have been evaluating this as well. All the information points to the same direction. That means that those populations that are highly linked to bone marrow samples and absent in peripheral blood are the best indicators of the quality of the samples or the degree of hemodilution. The problem is that this is certainly true and beyond any questioning for untreated samples. But when we get into the treated material, we should be aware that the therapeutic intervention taken might modify the way these populations or these populations might be affected differently. And also the time point of evaluation might have an impact on the amount of this population that we can observe. So the best thing that we can say now is that you should certainly actively look for these populations and try to identify them. If you have them well represented and you have a reference number for them in that specific time point and also that specific therapeutic regime, it would really help you to have a good idea whether the sample is hemodiluted or not. We are still actually also searching for a more accurate and precise way to define this, but so far this has not been possible to have this approach right.
Perfect, thank you. It looks like we have time for one more question. How many time points of MRD analysis do you perform in your cohort of patients, and how many months between each analysis?
Okay, for the work that we did at the beginning to evaluate the performance of the methodology, we actually did all the time points that the clinical team decided to evaluate. In a more prospective way, we certainly are doing this at the end of induction and after transplant. Beyond those two time points, there is rather heterogeneous, and it's on the clinical team shoulders to decide exactly the time point of evaluations and also, or the clinical trial objectives that have decided when to evaluate the samples in advance. I would say that this is also a question that is being actively trying to be answered by the current ongoing clinical trials, and we might have a better answer to this question in the near future.
Great, thank you. Thank you again, Dr. Flores-Montero, for your time today and your important research. We would also like to thank LabRoots and our sponsor, CytogNotes, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.
Goodbye, thank you.